pediatric neurologist at the University of Alabama, Birmingham. And in 1983, Dr. Percy, Dr. Vanya Holm, and Dr. Mary Coleman were the first physicians to recognize Rett syndrome in the United States. In 1984, Dr. Hugo Mosier, Dr. Holm, and Dr. Percy attended the Rett syndrome conference in Vienna, organized by our very own Dr. Andreas Rett. And since that time, Dr. Percy has truly pursued clinical and laboratory studies on this disorder. He established the Rett Center at Baylor College of Medicine, which we all know in Houston, and then later moved to the University of Alabama at Birmingham, and he's now the principal investigator of the Rett Syndrome, MECP2 duplication, and related disorders research consortium, natural history study, which he'll be talking about a bit today and in more detail on Friday. He's responsible for recruiting Dr. Huda Zogby, who we heard from on Monday, into these studies, leading to identification of mutations in MECP2, which he'll also talk about a little bit today. Since 1983, he's authored more than 120 scientific papers on Rett syndrome and is a co-author of our Bible, the Rett Syndrome Handbook. I don't think that we could ever truly capture in a bio sketch all of the contributions that Dr. Percy has given to our field. And for many of you on the phone today, you have met Dr. Percy and had your child assessed, and we're just so grateful to have you with us today to share your perspective and field some questions from our families. So on that note, if we can, Megan, who is with RettSyndrome.org, is going to turn the screen over to Dr. Percy, and we'll get started with your presentation.
Okay, good morning, everyone. I unfortunately do not have a camera. It died, and so it doesn't work. Probably it's to your benefit, because otherwise you might be blinded by the lack of hair that I have on top of my head. So we're going to talk about basically the Rett syndrome diagnosis, natural history, and some issues with care intervention. And on Friday I'll talk specifically about one clinical trial that we were engaged in. So with that in mind, I'm going to talk a little bit about the history of Rett syndrome and launch into diagnosis some specific issues related to the problems that we see in girls who have, or women that have this diagnosis, and then finish with the natural history and a brief presentation on what the care and treatment package looks like now and what it could look like in the future. So we all know Andreas Rett. He was a fine physician and gentleman who began to see these girls in the probably late 1950s or 1960s. He wrote, unfortunately, only in German, and it appeared only in an Austrian medical weekly newsletter. So therefore it wasn't read very broadly. He did make movies and travel around Central Europe and tried to engage other physicians, many of whom thought he was a little bit off, and others who said, well, I think I've seen this, but I haven't seen it very often, and they kind of just pushed him a little bit to the side in that regard. At the same time, actually, Bengt Hagberg was seeing similar girls with this disorder in Sweden. He traveled around the country. He was the principal child neurologist in Sweden at the time, and probably is regarded as the father of child neurology in that country. Unfortunately, both Dr. Rett, who died in late 1990s, just before the mutations were identified by the laboratory of Dr. Zogby, and recently, within the last couple of months, Dr. Hogberg also passed away. But nevertheless, he then began to be interested through a meeting of child neurologists in Europe about the issue of this disorder, which he presented briefly at that meeting. And he was informed then of the work of Andreas Rett. They had a chance meeting in Toronto in 1981 or so, and at that time, Bengt realized that this disorder really needed to be recognized as Rett syndrome. He was already preparing a manuscript, which ultimately was published in the Annals of Neurology in 1983. But he went back to the other authors, and they decided to call it Rett syndrome. This article changed our world dramatically. I myself was minding my own business in a basic science laboratory looking at complex lipid metabolism in brain, far removed from Rett syndrome. With the first girl that I saw, I was completely moved by this disorder and pursued it to the present time. This is the paper that Bengt Hogberg wrote in association with Jeanne Cardi, who is a well-regarded child neurologist in France, and two child neurologists from Portugal. And they reported on 35 cases. Of course, at the time, the mutation and cause of this disorder was not at all known. So, what is Rett syndrome? It is basically a neurodevelopmental disorder. It is not a neurodegenerative disorder. It's a neurodevelopmental disorder which begins generally in young females, rarely occurring in males, and is characterized by loss of ability to comprehend in the way that most people do, a significant communication dysfunction, unusual hand stereotypies, which may also be seen in the feet or around the mouth, but are most prominent in the hands, and generally significant problems with physical growth, including head circumference. Rett syndrome does follow a very clear temporal profile. Bengt Hogberg actually created a staging system, and it probably was relevant in the pre-mutation era, and at the time not much physical or occupational therapy was done, but it has really been passed over by this more general relationship of a temporal profile. The reason for that is the girls that we see now, and women, are certainly far different from those who were seen then, where therapies were not really heavily engaged. So early development appears to be normal. We have a recent publication which shows that early development is okay in many girls, but and most girls will develop the early features, but they don't necessarily develop them at appropriate time intervals. So the word apparently is carefully inserted there. Then there is an arrest of developmental progress, usually at the end of the first year of life, and then followed thereby is a regression period, most commonly seen between 12 and 30 months of age. 90% or so of the regressions occur then, with approximately 5% on either side of that. About age 3, but certainly by age 5, there's a definite stabilization of the pattern in these girls, and their eye contact becomes much, much better. It certainly is intermittent, but they do give intense eye contact, and that is maintained throughout life. Gradually, however, there is a slowing of motor functions, and that's related generally to an increase in muscle tone. Early on, often these girls have low muscle tone, and it gradually changes over time, going through a period of normal tone, and then in the teenage periods, or perhaps somewhat later, there is an increase in motor tone, and it's really not spasticity that one could see in someone who'd had, let's say, a stroke or a brain injury, but it's rather a rigidity of movement, which is more like what one would see later on in individuals with Parkinsonism. Again, in 1999, this mutation in MECP2 was identified in a small number of girls, and since that time we have recognized that there are at least 200 different mutations in this gene, and I will talk a little bit more in detail about some of the specifics of that. What is the relationship, however, between Rett syndrome and MECP2? Rett syndrome remains a clinical diagnosis because it is not synonymous with having a MECP2 mutation. You can have Rett syndrome with or without a MECP2 mutation. And MECP2 mutations also occur in individuals who do not have Rett syndrome. I'll talk more about that also later. And if anyone is interested in the database, which is supported by IRSF, rettsyndrome.org, and is maintained by Dr. John Christodoula in Sydney, Australia, and that is the website. One can go in there and look at all of the different mutations at quite a good deal of time and length. So we make the diagnosis based on a specific set of criteria which have been refined over the years. These were first elaborated after the 1984 meeting in Vienna and have been changed or modified periodically as we've gained more experience, and in particular since mutations were identified in 1999. So to have classical or typical Rett syndrome, you need to have a pattern of regression. If you don't have regression, then you don't have classic Rett syndrome. And it's usually followed by this recovery or stabilization period. You also must meet all of the main criteria, which are listed below, and all of the exclusion criteria. Supportive criteria, which were outlined in 1984 and then subsequently later, are not really required for the diagnosis of typical Rett syndrome. They're often present, but not always. So what are the main criteria? There is partial or complete loss of purposeful hand use, partial or complete loss of spoken language, and difficulties in walking. The gait is usually dyspraxic, which means that it's not purposeful, it's not steady, it doesn't go from point A to point B, but may kind of wander around, or in some girls there is complete absence of gait. In general, at the beginning, about 80% of girls learn to walk, and a percentage of them lose that ability. So by 10 years of age or so, about 50% or half of the girls will walk, and another 20% will walk with some degree of assistance, which could be as simple as guiding their arm or hands, or pretty significant support in walking. Nonetheless, even for girls who don't walk, we encourage very, very strongly that these girls be in a standing frame for a significant part of the day, mainly because standing is a normal posture. It's good for anyone to stand, but also it helps by supporting weight to build bone strength and even muscle strength as well. And then, of course, the stereotypic hand movements. The exclusion criteria, which we have, but I've never seen really, is evidence of traumatic brain injury, some metabolic disease or severe infection in early childhood, or abnormal development, which could lead to problems associated in the same way that are seen in girls with Rett syndrome. Now, for the atypical or variant forms of Rett syndrome, the story is a little bit different. Still, they have to go through a period of regression, but in this case, they have to meet only 2 of the 4 main criteria that were on the previous slide, and any 2, not any specific 2, and they must meet 5 of these 11 supportive criteria, which were initially elaborated by Bengt Hagberg and his associates in 1984. I'm not going to go through them all. They're here, and you can certainly look at them on the taped presentation. But there are a variety of criteria which could or could not be present, but which are required for the atypical diagnosis. So what do we know about Rett syndrome and MECP2? In classic Rett syndrome, more than 95%, probably closer to 96% of girls or women have mutations in MECP2. The other 3 or 4% do not have a mutation, and it could be because we have not completely assessed other areas of the MECP2 gene that could be important, or they could be related to other genetic mutations that we are not clever enough to figure out yet. Remember, I mentioned there are more than 200 mutations, yet 8 specific mutations account for about 60% of the girls, and deletions or insertions account for another 15 up to even 20% of the girls. So we're talking now that a relatively small number of mutations account for most of the individuals, and then the other mutations are present in one or only a handful of different individuals. Rett is mainly sporadic. It is not familial in most cases, by far. The majority do appear, however, to come from the male sperm, not from the male genes that he's carrying around, from new changes that occur in the rapidly developing germinal cell lines, which happen to be the sperm. We are very, very careful and say that no one should assign or accept blame for this. It is an uncontrolled situation that you simply have nothing to do with. Familial Rett syndrome is very, very unusual, and I'll talk about that a little bit later. And the variant forms account for about 15% of the total, and in our hands at least, in the variant forms of Rett syndrome, about 75% of those individuals have mutations in MECP2. There are other isolated mutations which may have features associated with Rett syndrome, may be quite similar, and that's probably a subject of another conversation. There are much more that we have learned throughout the time, and particularly since we began the natural history study. So what are the phenotypes that one may see in a female? Well, by and large, you're going to see Rett syndrome in the vast majority. The variant forms occur really on 2 sides of girls with Rett syndrome. Those that have perhaps better functioning are those with preserved speech. Those are girls who may speak in short phrases or very short sentences, but they certainly are not otherwise normal. And then girls who have very delayed onset after 6 or 7 years of age, or so-called form Frust, is identified by Bengt Hagberg more than 20 years ago. On the other side of the coin, there are girls who have very early onset, either with very, very abnormal development already shortly after birth or early onset seizures. Then there are girls who have mutations in this gene who don't really have Rett syndrome but are simply autistic-like or have patterns almost of psychosis. The issue of autism is very interesting. Girls with Rett syndrome may go through a period of autistic-like behavior, say from 12 months to 3 years, but that period generally is overcome when their attention becomes much more different and their eye contact improves. That's a great difference from typical autism, where the individuals definitely do not tend to give eye contact. And then there are a small number of girls, and a very small, who may appear to have Angelman syndrome initially, and then turn out really to have Rett syndrome. And the last two categories are really related to the individuals who have a mutation which otherwise would not be known if they had not had children who had Rett syndrome. And those are individuals who carry the gene, but because of a phenomenon known as X chromosome inactivation, a relatively small number of their cells have the gene actually expressed. And they may have mild learning disabilities or be completely normal. And nothing would be known about that unless they had affected children. In the males, the story is quite different. You can see Rett syndrome under a couple of scenarios. One is in which a situation in which they have a separate mutation or gene defect. And it's called 47XXY or Klinefelter syndrome. And so they therefore have the same X chromosome makeup as females. Or there are boys who have somatic mosaicism, that is, after the egg has been fertilized and they're early in development, something happens and there are actually two types of cells that are produced, one with a normal genetic makeup and one in which the X chromosome is defective in this gene. And so in that way they are also like girls. And then there are boys who have mutations but do not have Rett syndrome. They can have a very, very severe encephalopathy and a very shortened life expectancy, or they may have simply a mild mental retardation or cognitive impairment, and may or may not have progressive motor issues. There is another abnormality, and that is MECP2 duplication. That's actually, there's no mutation in the gene, there's just an extra copy of it. And we've known from studies in animals that too much of the gene is almost as bad as too little of the normal gene. What is the natural history? Growth. Girls tend to be quite small. The head circumference is reduced often as early as 1 or 2 months of age, and it gradually decelerates so it reaches the median value in the population, reaches the second percentile by 2 years of age. Weight and length follow a very similar pattern, so that these girls tend to be quite small overall. There are exceptions, but in general this is true. And the hands and feet are also small, feet probably more so than the hands. These are the growth curves. This is the head circumference curve, and you can see that already this average line for the Rett population is deviating from the average line for the so-called normal population, and it crosses the second percentile by at least 2 years of age. And this is a similar pattern for weight, where the girls are smaller, and, but they don't cross the second percentile. on average until about age 12 or a little bit later, and the length follows a similar pattern, perhaps crossing the second percentile just before age 12. Seizures are a common occurrence. They generally do not appear until 2 or 3 years of life. The EEG is generally abnormal in almost all girls. It's slower than one would see normally, and it may have epileptiform characteristics. That means that these are patterns that could generate a seizure, but they do not necessarily mean that it's a seizure. So we firmly believe that if a girl has an epileptiform EEG but no clinical seizures, there's really no need to expose them to treatment or medications, because the benefit is very little and the risk, even though it's small, is still enormous in terms of the risk-benefit ratio. So seizures should be treated if they actually occur, but if it's just an abnormal EEG, it's not necessary. This determination may require a video EEG monitoring for 1 to 4 days to be certain that what one is seeing in terms of abnormal behaviors actually are related to abnormal EEG and seizure activity. Overall, about a third of the girls require medication. A very small percentage of them, or less than 10%, have a requirement for a vagal nerve stimulator or a ketogenic diet. Sleep is also often disrupted. It could be related to infections, other issues such as hunger or constipation or GE reflux or other gastrointestinal problems, or it could be related to Rett syndrome. Many times we hear of girls going to sleep normally, but they're often awake in the night for one reason or another. And in many cases, they're just playing, and they go back to sleep. And if the parent can be assured that they're going to be okay, it's probably best for the parents to try to get some sleep as well, because we recognize that sleep hygiene for everyone in the family is essential. And if the mother and the father aren't sleeping well, then the health quality of the whole family is going to be adversely affected. There are a number of sleep aids that can be used. Antihistamines can be used. We don't recommend them on a long-term basis because they tend to lose their efficacy because a person develops tolerance. But intermittently, they could be effective. Melatonin will induce sleep. It does not necessarily prevent arousals. However, there are long-acting forms that are available, and if a girl can take a pill, because if you break up the pill, it loses its long-term capabilities, but it may be more effective in the long-term preparation. We do often recommend the use of trazodone, which is a side effect to produce sleep, and it can be quite effective. It doesn't produce a hangover and doesn't have any long-lasting effects. Personally, I'm an older guy, and chloral hydrate was available, and it was very well received. However, it's unpalatable in the current preparations, and unless you have a private pharmacy that can formulate it in a specific way, or your daughter has a G-tube, gastrostomy, it really is not a very useful preparation because of its lack of palatability. Breathing irregularities are common. We wish that we had an effective therapy. However, we are not aware that the breathing abnormalities alter the health or safety of their daughters. The hyperventilation or breath holding may be increased by new situations, agitation, going to clinic to see me, or even hunger. They typically reach their maximum between 5 and 15 years of age, and they may taper off. However, they may also bubble up at times when some agitation or stress or unknown feature pops up. In some cases, the air swallowing is tremendous, and one has to be very concerned that it could alter GI function as a result. But effective treatment for any of this is at present very elusive. There are clinical trials that are being planned to address this. GI issues are a problem really from top to bottom. I think you all know them better than me. Gastroesophageal reflux is very typical, and it can hurt a lot. It doesn't mean you have to vomit. It means you may bubble up gastric acidity into your esophagus, and it hurts. And unfortunately, these girls don't tell us what specifically hurts. They simply don't appear very happy. And that's one of the first things that we look at. Untreated, it can produce esophagitis, and that can go on to further more serious problems. So GE reflux needs to be assessed in anyone who has symptoms. Constipation is a similar problem. Almost all girls have constipation, and that generally requires some treatment either with special diets or Formin diets or use of Miralax or milk of magnesia. We have a small number of girls who have had gallbladder dysfunction. This is not gallstones necessarily, but simply it doesn't work properly. And if you've ruled out every other potential thing, you probably should ask your physician to assess the gallbladder. And this can happen even in very young girls, as young as 2 or 3 years of age. But it's not that common. Nutrition, we harp on a great deal. We have gastrostomies probably in 30% or more of the girls. These are done either because it's not safe to be fed by mouth, or you simply are not able to get in sufficient calories to maintain proper growth parameters. And we rely very heavily on the BMI. When the BMI falls below the 13th number 13 or below the 25th percentile in the normal curves, we become very worried. Very, very recently, we've been very impressed by the low levels of vitamin D in most everybody, including me, and we stress very, very frequently the needs to have adequate vitamin D in your diet, and also to check it in the blood, and the value needs to be not just in the normal range, but at least the number 50. So when you get the results from the doctor, and the doctor says, "Oh, it's okay," you want to know. I want to know what the specific number is. It should be above 50. Osteopenia is very common in Rett syndrome. That's just a reduced mineralization of bone. It probably is worse in girls who are non-ambulatory, and is worse in girls who do not have very good caloric intake. So it's something that one has to keep in mind, and therefore we push very hard for the vitamin D levels, at least 800 international units per day by mouth or G-tube. Scoliosis is also very common. More than 85% of girls will have this by the time they are quite mature. About 13% require surgery. It is something that can be retarded or prevented in some ways, particularly if your girls are non-ambulatory and tend to sit a long time. If be careful that they sit upright. They don't slouch one way or the other, because eventually they'll slouch in the same direction and the curvature of the spine will become significantly worse. Bracing above 25 degrees is recommended. We have no systematic evidence that bracing is effective. However, there is evidence in another population of children that bracing can be effective in slowing down or actually stopping the curvature process. So when you see a curve in the spine, certainly ask for assistance from an orthopedist, particularly a pediatric orthopedist. We also are aware that in scoliosis, what really is a problem is there's not only a lateral curvature of the spine, but there's also a rotation that occurs. And rotation is also something to be avoided. I've already talked about ambulation and the importance of walkers or standing frames or ambulation. It's very important that girls who can walk, that they be encouraged to walk all the time, even as adults. And the girls who don't walk should be in standing frames or walkers for a significant portion of the day, maybe an hour in the morning and an hour in the afternoon. Sexual maturation does occurs generally on time. There are some girls that have early onset of puberty, but in general the onset of menses is a little bit slower than the average U.S. population, but it generally occurs on time. There are many strategies for menstrual management. Jane Lane here has talked about it in great detail, and I would rely on what has been published to direct your treatment of periods. The cardiac conduction system is something that concerns us. At the QT interval may be prolonged, and prolonged in, say, 20% of the population, and it may change over time. So we recommend an EKG at the time of diagnosis. That is a heart tracing. It takes a very short period of time. Your general physician can order it. It's done usually in a hospital, and a cardiologist will interpret it. Your daughter doesn't need to be seen by a cardiologist unless it is abnormal, and medical treatment may or may not be required for this. But periodic assessment with an EKG, perhaps annually at their person visit, should be done, and the results conveyed to your physicians or your neurologist. The autonomic nervous system is another problem that we really don't have any direct way of dealing with. We recognize it. The interesting feature is that the girls or women don't seem to be upset by the extremely cold feet and sometimes hands that they have with discoloration, but we know that it's very off-putting for the parents and for us when we see purple lower extremities up to either the mid-calf or even the knees. So it's probably related to excess sympathetic nerve tone in the hands or in the feet, but there is no specific treatment for it, and as yet we have not been able to assess that or to deal with it in any effective way. Teeth grinding occurs commonly. It's usually in the childhood period and often disappears in teenage and later years. It's usually associated, as the hand stereotypies and the breathing abnormalities, with anything that causes agitation, excitement, anxiety, and coming to the physician, as I saw yesterday in clinic, is a good way to bring it out. And there are many other motor system abnormalities that we could discuss. And some of them are generally uncommon, but when they occur, they need to be addressed. That is tremor, myoclonus, and choreiform movements of the hands and even the mouth. Dystonia is one thing that is seen very commonly, particularly as the girls age up into adolescence, or if they're not very mobile, they may even see them in early childhood. And you can simply assess that when they're sitting, as if and their shoes are off. If their feet kind of curve in, that is, they bend to the middle, you can overcome that. And the best way to deal with it is to have them in fairly firm tennis shoes, or, if necessary, in an ankle foot orthosis, which keeps them in a normal position and doesn't allow a contracture to develop, which can occur over time. The phenotype-genotype relationships have been discussed in a great deal of difficulty, great deal of effort, and not really difficulty, but there's difficulty in saying that if you have a specific mutation, what that is going to lead to in your daughter. In general, mutations as the top 4 types are relatively less severe than the other mutations. But in a specific girl, it could be quite different. And that is related to a number of features which I'll talk about later. In general, the overall clinical severity of an individual child does tend to increase slightly with age as they become perhaps more have a greater increase in tone. And we do know that there are certain features that are associated with or lesser or greater severity. So girls who walk or have some preservation of hand use, or perhaps have a little later age of onset, seem to have a less severe overall involvement. This is a pattern of those specific mutations. So you can see this group of 3 here, and this one here, which is the C-terminal transitions. Those have a milder overall pattern of severity. However, if you look at the top or the bottom, you can see that they merge pretty significantly with all of the other mutations. So what are the warning signs or the different opinion that you need to take away? One is, as I said, the same genetic abnormality may provide a quite different outcome from one girl to another. That is related in part to X chromosome inactivation, and it can differ quite a great deal. We have looked at that in blood, but not in brain. We can't do it in brain. And what the relationship between the blood and the brain is not completely one-to-one. So, but still in blood, there were a high percentage of girls who had skewing of X chromosome inactivation. That means that more than 80% of their cells were expressing the normal chromosome. And in a smaller number, but still greater than the general population, about 10 or 11% were greatly skewed. That is, greater than 90% were expressing a normal chromosome. And interestingly, it was in both directions. About 5% had a better pattern, and 5% had a worse pattern. The genetic background of the girls is quite different. As we know, all people differ, so do girls with Rett syndrome in terms of their genetic background. And then a feature which is not well described or talked about, and that is the distribution of normal or abnormal X chromosomes in the brain. It can be quite different from girl to girl. So there are many features or factors that could be related to the different outcomes that one might see with the same mutation. And then certainly environmental influences can be quite profound. Just a simple issue of school programs. One school may have a better program than another school. That's a very difficult issue for all parents. And it requires a lot of energy on everyone's part to be certain that the best therapy programs are available in schools, and they should be equal all across the board. Quality of life is also important. We know that from the child health quotient that we do, that poor motor function is usually associated with better behavioral function because they don't get in trouble. On the other hand, better motor function causes more behavioral issues. They can walk around, they can get to the stove, pull things off the stove, even get out of the house. So the girls with better motor function have a greater worry for the parents than perhaps those who are more sedentary. We are currently evaluating the parent quality of life and hope to have that out in print this year. Survival is changing over the years. From the original population of Andy Rett, there are very few individuals who survive beyond age 25. Currently, our survival is greater than 50 years of age for 50% of the population. That's certainly not normal in terms of other females, but it's much better than was seen previously. Now we have a recent report that is just being published on survival, and just to indicate that there are a number of issues that currently and are still present, that is respiratory or cardiac issues associated with sudden demise. But still, we see very, very few children now who are extremely frail as opposed to those seen in the 90s and before that time. So we emphasize very strongly the needs for continued therapies and continued excellence in diet. The natural history of Rett syndrome, the study, was started in 2003. We've been enrolling girls since 2006. We had an initial strategy of our hope to enroll 1,000 girls, and we're actually over 1,200 at this point in time. And the purpose was to expand just those things that I've talked about. And we had sites at Boston, Baylor College of Medicine, Greenwood Genetics Center, and here at UAB. And we had travel clinics across the country, 4 sites twice a year, which led to about 40% of the individuals enrolled in the study. All of the data goes to this data management coordinating center, and this is what we use to report our results. The current enrollment is here, 940 with classic Rett syndrome, 166 with atypical forms, and then 99 individuals who were MECP2 positive but didn't have Rett syndrome. We have a new natural history study which we're busily trying to get activated. It's now expanded to look at Rett syndrome, MECP2 duplication, and Rett-related disorders separately and specifically. We've expanded the number of sites across the country, and we have stopped the travel clinics. We hope that the protocol is up online by July, and we can then switch from the current protocol to this protocol. The plans are to look further at the natural history, but also look at biomarkers, both the X chromosome and activation studies, as well as other genetic messages that seem to be related to Rett syndrome, and then to look at advanced neurophysiology and neuroimaging techniques. Interventions. We all know that 2007 was published a paper from Scotland showing that if you inserted a normal MECP2 gene in a mouse lacking the gene otherwise, and under the control of another medication, and then if you turned that gene on at various times, either the animals were pre-symptomatic or even desperately ill, that the phenotype was reversed considerably. Probably wasn't 100% normal, but they were greater than 90% similar to their litter mates. So this was an excellent proof of principle that if we had a treatment that could modify or improve the situation with MECP2, we could greatly affect this disorder. It confirmed that this is a neurodevelopmental disorder because you can change the neurodevelopment of individuals with an affective gene. And so we've been working very, very aggressively in a variety of cell types, including whole animals, single cells in culture, tissue slices, and even using skin fibroblasts from girls or boys who have the mutation in the MECP2. We can create stem cells from those and differentiate them to neurons and glia and to study them in great detail. These stem cells reflect or represent great advantages for testing drugs, and it can shorten, we hope, the period before we have effective treatments available. So the question is, early diagnosis essential? We have our own treatment trial, which I'll talk about on Friday, which involved adults or older women, older girls and women, 16 to 45 years of age, only because of the safety data that was available for that agent at the time. But the feeling is that if we are going to initiate treatment, it has to be done as early as possible. Particularly therapies that are going to affect the biology, the normal biology of an individual, they take time to have their benefits. You know very well that even in children who do not have Rett syndrome, that it takes a while for them to learn to walk and to talk and to function as adults in this time. So it is not something that you're going to have a treatment and it's going to make a sudden switch to being completely normal. So initiating as soon as possible is important. Remember, I said that the general regression occurs at more than 12 months of age. So what earlier clues to a diagnosis could be available? Well, if one picks up on the declining head circumference or declining weight and height, they're certainly not specific for Rett syndrome, but at least it should trigger in your mind or in the physician's mind that this is a possibility. And then even the stagnation of development or early period of regression, you need to impress on your physician. This is something that we really are concerned about. We need you to either at least refer us to someone who can assist us in this process. So it could be a geneticist or a developmental pediatrician or a neurologist that might make the diagnosis sooner. And one other feature which we hear very commonly, and that is that the infants, even though they're apparently normal, they're really tend to be passive and maybe too good because they eat and they sleep and they don't fuss a whole lot. And we all remember that our children who kept us up at night and were fussing all the time, and they probably have turned out okay. So that children who are passive could be an issue that needs to be addressed. There are prior clinical trials that have been done, except for the trial of lamotrigine for seizures. These previous trials really didn't lead to any new therapies. What are the plans now? Obviously, gene correction is important. If we could correct the abnormal gene and leave the normal gene working, that would be the ideal pattern. However, that is difficult. There are studies going on in animals now looking at gene correction strategies, but they have not really evolved to a level of clinical trials. There was an experiment some years ago in which bone marrow transplantation in mice was shown to have some benefit in asymptomatic males and asymptomatic females. However, there is a recent report now from 4 separate laboratories. One report, 4 separate laboratories failed to reproduce these results. So that was kind of a downer in regards to that. And finally, how could we affect X chromosome activation or inactivation of the normal allele? If we could turn on the normal X chromosome in all cells and leave the abnormal one silent, that would be, again, an effective treatment. However, the actual working of that is taking on a more difficult task, and although there are many labs looking at this, it has not reached clinical trials just as a gene correction. So we have a number of symptomatic therapies that are being used. Serotonin reuptake inhibitors can improve anxiety. The glutamate receptor blockers or antagonists can improve the glutamate hyperexcitability. And there are 2 trials in IGF-1, a full-length compound being trialed in Boston and soon to be expanded to 1 or 2 other sites. And the tripeptide, which is the trial that we at Birmingham and Baylor and at the Gillette Children's Hospital were involved in, and we are talking now about aggressively going on to further trials and because of the positive signals that we saw. So the IGF-1 treatment may well be a very, very appropriate one. There are one of the genes that MECP2 seems to interact with is BDNF, that's brain-derived neurotrophic factor, so that there are a number of agents which can restore BDNF activity. You can't give BDNF, it doesn't cross from the blood to the brain. But if we could restore BDNF activity, it would be thought to be a great boon. One thing we know from the tripeptide studies in the laboratory is it does restore BDNF levels to normal in relatively short term. And then there's a further kind of study, and RettSyndrome.org has funded a signal study at a Western university. I don't think I'm at liberty to mention it, but to look at the so-called stop mutations. That's about 1/3 of the girls with mutations in MECP2 have a stop mutation, and these compounds cause the mutation to be read to a complete end, so you get a full-length protein, whereas in the ordinary situation with a stop mutation, you do not get a full-length protein. And important, that is an important area to look at in the future. This is the current array of sites that are in our natural history study. I'm not going to read them off, but there are 3 additional sites that RettSyndrome.org has agreed to fund if we can get them approved by the NIH and by the data management system, and they will be at the University of Cincinnati Children's Hospital, or Washington University in St. Louis, and the Gillette Children's Hospital. We hope in that way to expand the coverage of clinics, particularly for the natural history study, but also just for clinics, so that one doesn't have to travel all over the country or at long distances to see a physician knowledgeable or a team knowledgeable in Rett syndrome. This is a young girl that I saw in California at a travel clinic. She was very engaging, as you can see here. And this is the first girl that I saw in Houston. In 1983, she's now in her mid-30s and is really the apple of her parents' eye. So with that, thank you very much.
Thank you so much, Dr. Percy. That was an excellent presentation. Following on to your comment about your very first patient of yours, I could say that you are also the apple of our eye. Thank you so very much for all of this information. It's overwhelming and impressive. We are at the top of the hour, but for those who can stay on, I have a number of really good questions in the queue. If we could take maybe about 10 minutes to cover some of them, and then, as promised, we'll export all of the questions that have been asked for Dr. Percy to develop a question and answer document, and we can send that out by email to all of our attendees today. Would that be okay with you, Dr. Percy?
Sure.
Great. Okay. So if we can, we've got about, why don't we take about 10 minutes, and I'll read some of the questions that have come in. So one of them is your opinion on current thinking regarding cognitive impairment in Rett syndrome, and as regards to Dr. Rett's earliest classifications, is dementia still considered one of the symptoms?
To answer the second part first, I would say dementia is not considered to be part of it. The problem is actually determining what or how these girls learn or communicate, because obviously they don't talk, they do not use their hands, and so the standard mechanism for measuring abilities or capabilities in individuals is through those two mechanisms. We do believe now with aggressive therapies in speech and language that the use of interactive communication strategies with these girls can be quite effective, and that the high end of that is with a computer-based strategy, which doesn't require really any output from the child in terms of hand use. And it's a technique in which the computer actually can tell where the eye is looking. So the eyes can be used to guide targets on a computer screen, and one can then develop a system of communication with those individuals. And so therefore, in a number of situations, it is said that these girls are able to communicate quite effectively and to do a significant amount of work which would give credence to the fact that they can communicate. Now, what the exact level of intelligence, that is, what their cognitive level is, still is an unknown. But I think as we have moved into, and I'm not done that, but if we have individuals who are capable of advanced speech therapies, we're learning more about communicating with them and learning exactly what they can or can't do. I think that the next stage of that is to have a actual testing of the methodology to see what it is that the girls can do, and to establish proof that there is a definite advantage to initiating that kind of strategy as early as is feasible. We have girls here in Houston, in Birmingham, and there are girls in Houston, but girls in Birmingham who are engaged in these computer-based techniques as early as 5 years of age, and some even earlier. We've had girls also who have been able to use iPads. Those are girls who have some hand function, but my own use of an iPad, I see that I touch something on the screen and I'm off to another area. So I think that that the iPad sure is a good technique, but it also could have some disadvantages by sending girls out in right field when they don't really intend that to happen. And perhaps the sensitivity of the device can be turned down so that those responses aren't seen. But there are a variety of techniques to look at cognitive function, and I think that we now know that these girls are much more capable of doing things than we would have given them credit for 30 years ago.
Thank you, Dr. Percy. I agree, and one of our mantras is to ask everyone working with our girls and as our parents to presume competence. We have a number of webinars coming up today and tomorrow that will help parents practically learn skills for this. The very next webinar we have is speech-language pathology with Teresa Bartolotta, and tomorrow we have an entire day of 3 extended webinars that go into these questions more in depth. So I encourage everyone to register, and remember, even if you can't attend live, if you register, we'll be able to send you some links to those presentations. We also have a number of questions about GI issues, DEXA scans, and osteopenia. If I can, just give a plug to Dr. Motil, who will be presenting on that topic at 4 o'clock Eastern today. So in case we don't get to it live, you do have an opportunity to hear directly from Dr. Motil on that topic. So I don't want to skip over important questions, but I do want to take advantage of our time live with you today. So Dr. Percy, if I can move on to another question, I think this is one that is particularly suited to your experience with Rett syndrome, and it's a parent who's asking about just how many waves of regression, stabilization, reacquisition of skills can we expect in our girls? Families, does that question make sense?
I think that in general one sees a pattern of great regression where they lose definite hand use or communication skills, and it's a single phase which occurs early in childhood. I think if you see patterns later on where they are changing, there are a number of factors which could be related or the cause. So one would be, let's say, in adolescence, who seem to be doing less and less, and that is the change in their motor capabilities. And that happens naturally. It's not a definite regression. It's just a change in motor function such that they have greater difficulty in moving easily. But there are other factors. So let's say GI complaints, and scoliosis, a number of other factors could be related to what appears to be a secondary regression. If they have significant air swallowing, that could completely alter their ability to function in a typical way. So I think that if one sees a pattern of declining ability, one needs to just not think that this is just another regression, but rather, is there something else going on that needs attention?
That's a very good explanation. Thank you. It's not very predictive. Okay, why don't we see if we can pick up one more question here, and then we will move into developing the Q&A document.
Okay.
Okay. A lot of questions about sleep. So I'll see if I can kind of put them into one question. One is from a parent of a very young child, a two-year-old, and her child seems to need increasing number and length of naps during the day. And how does that work with kind of the nighttime awakenings that happen? And you had talked about some drugs that can help help our girls sleep, and if you could maybe go back to that slide again.
Okay.
That was a separate question from the parent of the younger child. Her question was about naps, but we also had another question about what drugs you recommend for sleep disturbances.
Yeah, so the issue of having take naps in the day usually means to us that the nighttime sleep is not effective. So it's not a question of looking at what's happening during the day, but what's happening during the night. And so at that point in time, I think I would recommend a sleep study, which is done in a hospital. And they do it for 1 or 2 nights, and they measure certain physiologic features, looking both at breathing capabilities as well as a limited EEG pattern, and they can look at stages of sleep and see how the girl is doing during sleep. If there are frequent awakenings, if there are not frequent awakenings, but generally you'd expect to have frequent awakenings. If there is a problem during sleep in which the girl has noisy breathing or snores, that usually is an obstruction in the upper airway or the middle airway, and it's not necessarily related to Rett syndrome. It could just be that the tonsils or the adenoid is impeding normal breathing. When you sleep, you tend to relax your mouth and structures in your mouth, and maybe the airway is just being impaired, so the sleep is disrupted. So I think a sleep study is quite important. For a sleep aid, at 2 years of age, it's a little bit concerning to use a medication because we're not completely comfortable with, say, trazodone in a 2-year-old. But you certainly can use melatonin. Melatonin is a normal compound. Everybody has it in their body. You're simply giving them an extra boost. It's a hormone which has a different pattern of behavior during the waking time and the sleeping time, and it's increased during sleep or the onset of sleep. And so I would encourage at least the implementation of melatonin, but again, a sleep study to be certain that there aren't other factors that are altering the ability to sleep in a normal way, such as upper airway obstruction. I hope I answered that.
Yeah, very good. Thank you. Okay, well, we've gone a little bit past the top of the hour, but I think you've gracefully answered quite a few important questions. Thank you so much, Dr. Percy. We look forward to speaking with you again on Friday in more detail about the natural history study and the clinical trial that you're involved with. We'll also be hearing from Dr. Walter Kaufman about the IGF-1 trial and from Dr. Steve Kaminsky, Chief Science Officer, about the overall research strategy, particularly about clinical trials, treatments, and translational research. So thank you so very much. I want to thank all of our attendees. Yeah, I want to thank all of our attendees from around the world who attended today. We hope that you got a lot of value from today's session, and we will make every effort to get your questions answered. Thank you for submitting them. We at rettsyndrome.org believe that it's critically important to educate ourselves about the care of our children, and it really does influence their development. They are not bound by their genetics. They will have stronger, healthier, more wonderful lives if we educate ourselves about our syndrome and really make the effort to put these recommendations into practice that we're hearing this week from our experts. So thank you so very much. We thank our sponsors, Tobii, Dynavox, and Ameripride, for supporting the webinars, so you could have these at free of charge. And we will get recordings of these sessions out to you shortly. Thank you again, and we hope you enjoy the rest of the webinars this week. We will now conclude today's webinar, and thank you again, everybody. Bye-bye.